اوكي، بسم الله الرحمن الرحيم. السلام عليكم جميعا، كل عام وانتم بخير. اتمنى لكم ان شاء الله الموفقيه والنجاح دائما. واحنا بهاي الايام مال كورونا نتمنى ونطلب من الله سبحانه وتعالى ان يدفع عنا وعنكم جميعا الوباء والبلاء. Today we are talking about analgesics, and as this topic is very important for any physician and especially for the anesthesiologist, we divided this presentation into two parts. This is the first part, and the second part maybe in the next week, inshallah. And now we are in August. The weather is so hot. And by this occasion, what's the relation of hot weather with the opioid? Any relation of hot weather with the opioid? Another thing, that all smartphones reported ultraviolet index. Why this smartphone reported frequently the ultraviolet index? What does that mean, ultraviolet index, and what's the importance in relation to anesthesia? The ultraviolet index provides a daily forecast of the expected risk of overexposure to the sun. For example, melanoma, basal cell carcinoma. According to the level of ultraviolet index, the risk of melanoma and basal cell carcinoma increase. Actually, we are not familiar with these diseases, but if you have any friend specialist in dermatology, he will tell you about the number of the patient complaining of these two malignant diseases, basal cell carcinoma and benign disease melanoma. The index, ultraviolet index, predicts intensity level on a scale of 1 to 11 plus, where 1 means a low risk of overexposure, 11 plus signifies an extreme risk. A new mouse study has found that continuous exposure to ultraviolet radiation causes the release of endorphin. Endorphin is an endogenous opioid, leading to physical dependence, tolerance, and addiction-like behavior in the rodent. And the relation with our daily work in anesthesia, if this continuous exposure to sun lead to continuous release of endorphin, we may face a resistance to the opioids like morphine, and the patient may need more analgesia. Please bear in your mind that in the hot weather in Iraq, especially in June, July, and August. In this presentation, there will be answers of the following questions. What's the neuropathic pain? Neuropathic pain is a type of pain. Why non-steroidal anti-inflammatory drugs may trigger asthmatic attack? Patients with asthma always avoid non-steroidal anti-inflammatory drugs. Why salicylates must be avoided in children? What is the Reese syndrome? And why COX-2 inhibitors are free of or with less gastric side effects? What's the reason behind that? And why COX inhibitor may produce CVA attack or MI attack in patient. Does aspirin act on COX-1 or COX-2? And the last question, can naloxone reverse the action of the tramadol or not? The answers of all these questions will be found throughout this presentation. And please, at the end of the presentation, if any of these questions wouldn't be answered, please allow me to answer it. This is a statement. When you do what is optimal ethically, then you would glorify yourself and please others. When you don't do what is optimal ethically, then you would harm yourself only. Any comment about this statement from any of you? Mariam Ali.
نعم أستاذ.
Do you have any comment about this statement?
No.
Ahmed Abbas.
نعم أستاذ واضح.
Do you have any comment?
لا أستاذ صحيح يعني it is true.
Do you have any comment or example? Ali Nazam. Okay. ناخذ example. يعني إذا واحد يحترم أبوه على سبيل المثال. example بسيط حتى قلت إذا واحد يحترم أبوه.
عفوا أستاذ ولا قاطع حضرتك، الصوت يمنى من مايك مفتوح، فإذا ما تصير زحمة تقدر تسوي لنا ميوت للأوب.
But simple example to be clarified. إذا واحد يعني يحترم أبوه، يمجد أمه مثلا، يمجد أبوه، يذكرهم، يؤدي حقوقهم، فهو ده يسوي الأوبتيمال ethically. فإن such case هو glorify يعني himself، يعني يمجد نفسه، وفي نفس الوقت يبث السعادة والفرح لوالديه اللي أدى حقوقهم. بس إذا ما أدى حقوق والديه، هو بالحقيقة الوالدين ما راح ينقص منهم شيء، لكن بالحقيقة هو يؤدي نفسه من خلال خروجه من دائرة الأخلاق الحميدة. فكل شخص تصرفاته السيئة تعود عليه فقط، تصرفاته الإيجابية والحسنة راح تعطيه نقطتين. النقطة الأولى الناس تحترمه، والنقطة الثانية إنه هو ينشر السعادة بين الآخرين من خلال تقديمه للأخلاق الحميدة. Now return back to the presentation. Analgesics is a drug that selectively relieves pain by acting on central nervous system or on peripheral pain mechanisms without significantly altering consciousness. Pain, also called as analgesia, is an unpleasant sensory and emotional experience associated with actual or potential tissue damage or described in terms of such damage. This definition by International Association for the Study of Pain since 1979 Until now, this definition is a solid definition because it includes very important principles in relation to pain. In this definition, there is a count of not only sensory experience, but advanced to the emotional experience, and sometimes associated with actual or potential. Potential means there is no actual tissue damage at the time being, but there is potential liability for tissue damage, and sometimes described in a term of such damage because there is no damage at all, as we will see in the maybe next slide. Pain, according to this definition, is whatever the patient says it is, unless proven otherwise by poor adherence to an agreed treatment plan. If the patient says, I have pain, means he has a pain. So it is subjective, not objective, not like blood pressure measurement by sphygmomanometer or pulse rate counting by arterial feeling. It is subjective by the feeling of the patient. And if you say there may be a criticism to subjective assessment of pain, I agree with you, but I will ask you, do you have another measure to assess pain other than the patient saying? For sure, no. So we have to obey this statement and depend on the subjective assessment of the pain by the patient him or herself. Many people report pain in the absence of tissue damage or any likely pathophysiological cause. If they regard their experience as a pain, it should be accepted as a pain. For example, phantom limb pain. They have pain in the limb, which is not there. If the pain is always associated with actual or potential tissue damage, then they should not feel pain on the limb where there is no tissue at all. So it is described in terms of such damage. So till 1960s, they were sent to the psychiatrist thinking they must be mad. Now it is well-established phenomenon with the clear pathophysiological explanation of the phantom limb pain. So we have to obey what the patient says regarding his or her feeling of pain. And this slide may be repeated for you because the same slide in the lecture of neurophysiology, but here it is important to be mentioned. This is the pathway of the pain, feeling of pain, sensation of pain, starting from the peripheral receptor, here the foot and here the hand, and from this receptor to the dorsal horn, and in the dorsal horn there is synapses ending of the first order neuron and start of the second order neuron, and there's a crossing to the contralateral side, and from this ascend till reaching the thalamus in the contralateral side, and in the thalamus there's the second synapse with the third order neuron that extend to the cerebral cortex, from the thalamus to the cerebral cortex. And this is through the lateral, mainly lateral spinothalamic tract, and also there is anterior spinothalamic tract. While here in the sensation of touch, if you look at this, this is the foot and this is the hand. From this side to the actually not to the horn, not to the gray matter, it is to the white matter and ascend ipsilaterally till reaching the medulla oblongata. And in the medulla oblongata, there is the first synapse with the second order neuron, and the second order neuron in the medulla oblongata cross to the contralateral side, and from the contralateral side ascend to the thalamus, and in the thalamus there is another second synapse with the third order neuron that extend to the cerebral cortex. And this is the main differences between the sensation of pain and temperature and the sensation of touch. In this slide, there's a classification of nerve fibers. Nerve fibers classified into 3 types, type A, B, and C. And type A further classified into alpha, beta, gamma, and delta. And in relation to our topic today, the pain, we have 2 important fibers. Through them, pain transmitted and sensed in the brain. First one is the delta A, delta transmit pain, and the second one is type C. And in the type C, we have somatic nerve and autonomic sympathetic nerves. Both of these types of nerves responsible for the transmission and sensation of pain. Here again, the classification with more details. And regarding the types of pain, can be classified according to the source of the pain, maybe visceral, somatic, or neuropathic. Neuropathic means affecting the nerve itself, the problem in the nerve. For example, post-herpetic neuralgia, trigeminal neuralgia, intercostal nerve problem. Any problem related to the nerve itself is a neuropathic pain. Here, visceral pain, somatic pain. Somatic pain from the muscle, tendon, ligament, and joints, cartilage, somatic pain. Visceral pain from all the visceral organs, GIT, renal, respiratory lung, trachea, cardiac, any visceral structures. And we can classify pain according to chronicity into acute and chronic pain. And I have to add something related to neuropathic pain, that any chronic pain with the time, with certain changes we will talk about next year, inshallah, when we're talking a presentation about acute pain management and the chronic pain management. There are several changes happened with any chronic pain, whether it was visceral pain or somatic pain. These changes lead to be associated with neuropathic pain. Means the chronic pain almost always involve neuropathic pain in addition to the original cause of pain, whether it was visceral or somatic. Types of pain. Acute pain, we can call it physiological pain. Chronic pain, we can call it pathological pain. Acute pain, mostly nociceptive. واحد ينجرح appendicitis, for example, cholecystitis. There is nociception, while chronic pain mostly neuropathic, I have just said in the previous slide. Nociceptive pain regarded as a symptom of a disease. Right iliac fossa pain, symptom of appendicitis, while the chronic pain, a disease itself, a disease of nervous system. In the acute pain, the treatment of disease cure pain and it is self-limiting. Doing appendicectomy will cure the right iliac fossa pain, while the chronic pathological neuropathic pain difficult to be treated and may be sustained for years. In acute pain, there is simple relationship between pain and tissue damage, while in chronic pain, dissociated relationship between pain and tissue damage. In acute pain, the pain proportionate to the clinical finding, while in chronic pain, it is disproportionate to the clinical finding. To manage pain, we have to assess pain. We have to assess pain to know this pain, whether it is mild pain, moderate pain, severe pain, and then to decide the lines of management. And for the assessment of pain, we have different tools to assess the severity of pain. Starting from answering of this question, patient able to communicate well or not. If he is able to communicate, then we have three tools to assess the pain. If he is unable to communicate, then we have this faces pain assessment scale, also called Wong-Baker faces pain rating scale, by looking at these faces and signs towards the face suitable for his or her pain. And if you look, we have here 6 faces. Face 0, smiley, means no hurt at all, while face number 5, hurt worse. And in between, there are several faces representing the scales of severity of pain. If the patient able to communicate well, then we have 3 tools for the assessment of pain. Here, there is verbal rating pain assessment scale, and in this scale, the patient can describe the pain with mild, moderate, large, or worse pain, very severe pain, or no pain. And for a numerical rating scale, we have 11 number from 0 to 10. 0 means no pain, 1 very least pain, 10 the most severe pain. And for the visual analog scale, also we can assess the pain from scaling from 0 to 10, and 0 means no pain, while the 10 the worst pain. We will talk in some details about these tools for the assessment of pain in the next maybe for 3 slides. First, verbal rating scales. In this scale, pain is described as none, mild, moderate, or severe. This is the usual way a patient expresses pain. This scale is short, easy to use and understand, especially in elderly and illiterates. Patients' lack of reproducibility makes this one less suitable for research purposes. This is about the verbal rating scale, and regarding the numerical rating scale. It is most commonly used in this. The two extreme experiences of pain is noted and has a numerical scale between no pain and worst pain imaginable. 0 correspond to no pain and 10 correspond to the worst pain imaginable. And regarding the visual analog scale, which is the third two, it is similar to the numerical rating scale. There is a 10 centimeter horizontal line with a label of no pain at one end and worst pain imaginable at another end. The patient is asked to mark on this line where he feels the intensity of his or her pain lies. The distance from no pain to this mark indicates the severity of pain numerically. The device has line on the patient side and a numeric scale on the clinician side. Visual analog scale is a simple, efficient, valid, and minimally intrusive method that correlates well with other reliable methods. The disadvantage is that it is more time consuming than other instruments. There is some difficulty in using and understanding this scale in the elderly patient, and we already said that verbal analog scale more suitable for elderly patients. The faces rating scale, it is commonly used. The patient is asked to point at various facial expressions ranging from smiling face, no pain, to an extremely unhappy one, the worst possible pain. It is used when the communication with the patient is difficult, as with pediatric and deaf and dumb patients. Now, after the assessment of pain, we can classify or decide the severity of pain into three categories: mild, moderate, severe. And an example of these categories, example for mild pain, is in pain with inguinal hernia, varicoses, varices, laparoscopy. And for moderate pain, hip replacement, hysterectomy, jaw surgery, while for severe intensity pain, thoracotomy, upper abdominal surgery, aortic surgery, knee replacement. And according to the severity of pain, we have several lines of management. Some of these lines related to, for example, mild intensity pain, paracetamol, wound infiltration with local anesthetic, non-steroidal unless contraindicated, and regional block. And sometimes we may add weak opioids or rescue analgesia with small increments of intravenous opioid if necessary. Regarding the moderate pain, paracetamol and wound infiltration with local anesthetic, non-steroidal anti-inflammatory drug, peripheral nerve blocks, single shot or continuous infusion, or opioid injection, IV PCA, patient control analgesia. And for severe pain, we can start by the same management of mild and moderate, but we can add epidural local analgesia or major peripheral nerve or plexus block or opioid injection by IV patient control analgesia. We have multimodal pain treatments: preemptive, preventive, local anesthesia, epidural analgesia, non-steroidal, steroids, paracetamol, opioid, and adjuvant drugs. And maybe the only big term here is preemptive analgesia. Preemptive analgesia means supplying the patient with analgesic before the first stimulus And you know that the first stimulus during surgery is the skin incision. So before any skin incision, starting the analgesia, which is a term known as preemptive analgesia, and they found that the preemptive analgesia will reduce the requirement of pain intra and post-operative. Here the pain cycle, pain pathway, and accordingly different modalities of pain management, starting from transduction. The transduction occurs in the receptor at the site of pain, and here non-steroidal COX-2 inhibitors, antihistamine, topical local anesthetics, all these can work here at the site of transduction. And regarding the conduction through the peripheral nerve, the peripheral nerve block with local anesthetic can be beneficial. And through the transmission in the spinal cord, the epidural blocks, very effective. And here also there is what is called modulation. And in modulation, opioids, clonidine, COX-2 inhibitors, all these can work. And regarding the perception of pain, as you find here, perception of pain centrally in the brain, opioids, paracetamol, clonidine, ketamine, gabapentin, tricyclic, all these can act well. And for the CNS responses, CNS response to pain may be with a spasm of muscle, with a tremor, and in these two situations, muscle relaxant may be beneficial, and beta blocker also may be beneficial. Riyam Ahmed. ريام أحمد مكتوب قدامي سيف أي العبيدي، ما راح أقدر أحفظ اسم أبوه لأن مكتوب سيف أي العبيدي. سيف تسمعني؟
العفو أستاذ. ريم أحمد.
سيف أي العبيدي مكتوب قدامي. منو سيف أي؟ ريام ماكو، سيف ماكو، ظفار أكرم.
عفوا أستاذ.
منو؟
ريم أحمد حضرتك.
حضرتك ريم أحمد؟ لو ريام.
نعم، الصوت كله جاي يقطع يمي. ريم أحمد.
وشو مكتوب؟ REIAM هي هيك؟
لا أستاذ، أنا بالعربي مكتوب. العفو، عبالي حضرتك ريم أحمد. أسف.
ريم أحمد فارس.
نعم أستاذ.
منو؟
نعم أستاذ، أنا ريام أحمد.
يلا ريام. اوكي ريام.
اي نعم أستاذ.
ريام هي CNS response. ها؟ مكتوب muscle relaxant. صحيح؟
نعم أستاذ.
يعني شنو ذول نسوي لهم تيوب نعطيهم muscle relaxant؟
بس العفو أستاذ، الصوت يقطع.
ذول شنو نسوي؟
بس العفو أستاذ، ممكن تعيد السؤال لأن الصوت يقطع.
اكو muscle relaxant مكتوب here in the management of pain.
اي نعم.
يعني شنو نسوي لهم تيوب ذولا نعطيهم muscle relaxant ونسوي لهم تيوب؟
ما أعرف أستاذ.
جود. بس اريد اسال سؤال، يعني الكل عندكم صوت كذا يقطع؟
استاذ قبل شوي كان يقطع الصوت، هسه حاليا لما قربت على المايك راح يعني التقطع، بس قبل شوي كان يقطع.
يعني اذا يقطع عندي another source of net حتى اغير، اذا الامور زينه حتى استمر.
استاذ انا بالنسبه لي
شكراً.
حاليا
العفو، اذا تقدر تغير يا ريت، لان حتى التسجيل عنده وقف.
احول الشبكه.
استاذ العفو، اكو طلاب يمهم الصوت واضح وطلاب يمهم الصوت يقطع. انا يمي الصوت واضح بس بعض الطلاب عندهم الصوت يقطع.
معناها مو من يمي اذا طلاب،
بالضبط ظاهر الخلل يم الطلاب.
لو كلكم كان قلنا الخلل يمي. اي زين، اذا صارت مره ثانيه غير السورس اوف نت بالنسبه لي. اوكي تو كونتينيو. هنا المقصود بالمصل ريلاكسنت هو مو المصل نون ديبولارايزنج او ديبولارايزنج peripheral muscle relaxant. المقصود هنا central muscle relaxant used in most medication to relieve spasm. Most of those work in rheumatology, pain, neurology, orthopedics. Most of them used a mixture of paracetamol with muscle relaxant, central muscle relaxant, to relieve the muscle spasm. And the muscle spasm is one of the responses of the brain to the pain. So with the time becomes the main problem of the patient is the muscle spasm, and to be relieved by using central muscle relaxant, not peripheral muscle relaxant. So here no need for and nowhere from affecting the respiratory muscle or voluntary muscle. Treatment options. We already said we have non-opioids analgesics. We have weak opioids, codeine, tramadol, for example, or combination of paracetamol with codeine or tramadol. We have strong opioids, several types of strong opioids. We will talk about in details in the second part of this presentation. And also we have adjuvant like ketamine and clonidine. And if we talk about non-opioids, there is paracetamol, can be used intravenously, start 30 minutes before the end of surgery, or by using oral administration as soon as possible, the duration as long as required. Here, the dosage can be 1 gram by 4 accordingly per day. 2 gram paracetamol per day can be accordingly. Thus, dose to be reduced, for example, to 3 times per day in case of hepatic insufficiency. And if we talk about codeine mixture with the paracetamol, here the combination consists of 500 milligram of paracetamol with 30 milligram of codeine can be used. And also regarding the non-steroidal anti-inflammatory drugs, we have 2 important IV types, ketorolac and diclofenac, can be used ketorolac 3 times per day in a dose of 30, common dose 30 or 40 milligram, and by IV injection only. And regarding the diclofenac, 2 times of 75 milligram can be used IV or IM, and we can start oral administration as soon as possible according to the required duration. Here the analgesia can be classified into opioids and non-opioids.
العفو أستاذ.
تفضل.
عفوا أستاذ، بالنسبة للدايكلوفيناك يعني النوعين، مو اكو دايكلوفيناك صوديوم واكو دايكلوفيناك بوتاسيوم، فهن اثنيناتهم نفس الدوز نعطيهم؟
نعم. اوكي
عفوا استاذ سمعتني؟
انت سمعتني لو لا؟ your opinion.
العفو استاذ، سالت بالنسبه للدايكلوفيناك، اكو دايكلوفيناك صوديوم، اكو دايكلوفيناك بوتاسيوم، اقصد الدوز مالتهم اثنيناتهم يعني مرتين باليوم 75 ملغ.
نعم the same.
اشكرك استاذ.
Opioid and non-opioid site of action. Opioid, the site of action, spinal cord, cortex, thalamus. Non-opioids mainly peripheral and subcortical in the thalamus also. In the opioid, we have antagonists like naloxone, naloxone, and levodopa, while no antidote in the non-opioids. Uses of opioid in severe anti-pain, canceramide, anginal pain. In non-opioid, dull pain, headache, toothache, and fatigue. Efficacy high with opioids and low with the non-opioids. The efficacy. حنان سلمان.
نعم أستاذ.
أخذنا الإفيكاسي بمحاضرة الجنرال فارماكولوجي. What does it mean efficacy?
دكتور يعني ال effect of the drug on the body.
Okay. The ability of the drug to reach the desired effect or the desired role of the analgesic. And here the efficacy of opioid is high while the efficacy of non-opioid is low. Sarah Hassan.
نعم أستاذ.
Can we increase the efficacy of non-opioid by increasing the dose?
يعني أتوقع لأنه اللي أدري به مثلا كيتورولاك يعني قاريته أنه 30 ملغ مالته يساوي 10 ملغ أوف مورفين، فأتوقع أنه يصير يعني.
Here we are talking about non-opioid between two brackets, non-steroidal and the non-steroidal unable, whatever the dose used to reach the effect of the opioid. And some drugs in general, with increasing the dose, we can increase their efficacy, but sometimes associated with their adverse effect. Mechanism of action of opioid, acting on opioid receptor, mu kappa, sigma, gamma, and relieve the pain through the release of endorphins and encephalin. While here in the non-steroidal inhibits prostaglandin synthesis by inhibition of cyclooxygenase enzyme. We have several adjuvant analgesics, antidepressant, anticonvulsant, alpha-2 adrenergic agonists like clonidine, disease-modifying anti-rheumatic drugs, GABA agonists, gabapentin, pregabalin, NMDA receptor antagonists like ketamine, corticosteroids, skeletal muscle relaxant, we have just talked about, central relaxant, local anesthetics, and topical anesthetics. For example, we have clonidine and ketamine, and the clonidine can be administered orally, intravenously, or perineurally. Perineurally means with the local anesthetic in the regional anesthesia, whether it was central regional anesthesia like epidural or peripheral regional anesthesia like the blocking of peripheral nerve. However, the side effects could be significant, means the side effect of clonidine. The most important ones are hypotension and sedation. Using of clonidine associated with hypotension and sometimes severe hypotension, and also associated with sedation of the patient. And ketamine can be administered via oral, intramuscular, or intravenous routes. It has also significant side effects. We will talk about in details in the second part of this presentation. Also, we have continuous peripheral nerve block. Continuous peripheral nerve block are being increasingly used for two important reasons. First, they may provide more selective but still excellent post-operative analgesia. More selective. I will give you example for that. In post-operative pain for patients with total knee replacement, they were using the epidural catheter in the past for the management of post-operative pain. And you know that this epidural affects bilateral lower limb, and this may interfere with early mobilization, which is essential part of the management of patient post-operatively by the surgeon. So with the time, they changed the practice from continuous epidural analgesia to femoral nerve block analgesia, continuous femoral nerve block. So becomes more selective. And after that, they observed that femoral nerve supply most of the muscles of the thigh anteriorly and can affect the mobility of the patient post-operatively. So change the practice from femoral nerve to the saphenous nerve only through what is called adductor canal block. So here, continuous peripheral nerve block, more selective, but still providing excellent post-operative analgesia. And another reason, reduced need for opioids over an extended period. Also, the peripheral nerve block avoid the side effects associated with central neuroaxial block, such as hypotension and wide motor blockade with reduced mobility and proprioception, and complications such as epidural hematoma, epidural abscess, and paresis. And if you look at these three complications regarded as hazardous actually complication, all these can be replaced and avoided by the using of continuous peripheral nerve block. And this is the importance actually of the peripheral nerve block over the central nerve block. And still we are in non-opioid analgesics. The first part, non-steroidal anti-inflammatory drugs. And under this headline, we have several groups, not drugs, groups of medications, all of these under the term of non-steroidal anti-inflammatory drugs. Second one, COX-2 inhibitor like celecoxib, rofecoxib, and third one, para-aminophenol group, which includes acetaminophen and phenacetin. The para-aminophenol group, the mechanism of action, we will talk in detail and maybe in the next slide, but here to mention that this act by inhibition of prostaglandin synthesis in the central nervous system. They have antipyretic and analgesic effect, weak or no anti-inflammatory effect because they have less effect on COX in the peripheral. No anti-platelet effect, lack of many side effects of aspirin. So in the non-steroidal anti-inflammatory drugs, we have anti-inflammatory effect, while in the acetaminophen, no anti-inflammatory effect. Phenacetin no longer used because of renal toxicity. I put this slide for non-surprising if you look at the name of these drugs in any textbook. Uses with other preparation with aspirin and caffeine. So stop because of its effect on renal system. Acetaminophen, which is also called paracetamol, actually four important mechanism of action have been stated. One, potent inhibitor of prostaglandin synthesis within the central nervous system. Blocking impulse generation within the bradykinin sensitive peripheral chemoreceptor. Flat antagonizing an NMDA receptor and substance P in the spinal cord. And the fourth mechanism, inhibition of spinal nitric oxide. All these mechanisms have been stated, but maybe the exact, precise, well-known mechanism of action, not well-known till now. We have talked about the pharmacological action, and regarding the pharmacokinetic, this drug rapidly absorbed from GIT, the peak plasma 1 to 3 hours, the dose 0.5 to 1 gram every 6 hours, metabolized in the liver and excreted in the kidney with urine. Clinical uses: mild to moderate pain, reduce elevated body temperature. For example, patient under 12 years for children with viral infection. We will talk about this problem that prevent the use of non-steroidal anti-inflammatory drugs in such age group. And allergic to aspirin, pregnant women, gout patients. Adverse effect: no significant side effect with therapeutic dose. Acetaminophen should be avoided in alcoholic patients. Nearly half of the people who combine the two, alcohol and paracetamol, reported health problems related to their kidneys. Large dose, 10 to 15 gram, means 20 to 30 tablets of 500 milligram causes hepatic necrosis. Paracetamol toxicity. In paracetamol toxicity, the symptoms start in the first 2 days as nausea, vomiting, anorexia, abdominal pain. And in the third day, there may be encephalopathy, coma, and death. The treatment by using of gastric lavage, activated caracol, sodium or magnesium solution these elements regarding as chelating agent to decrease the absorption of the ingested tablets. And the antidote of the paracetamol, after absorption of the paracetamol, we can use the antidote N-acetylcysteine oral. Acetaminophen combination is an effective analgesic for mild to moderate pain, but to manage more severe pain, it is combined with codeine, one of its derivative, or one of its derivative of other drugs, like can be combined with codeine, oxycodone, tramadol, and hydrocodone. All these drugs can be combined with paracetamol, and this combination results in more efficacious analgesic drugs. And also, the non-steroidal anti-inflammatory drugs can be combined with codeine, oxycodone, hydrocodone, and tramadol, leading to a more synergistic effect of analgesics. Now, we will focus more on non-steroidal anti-inflammatory drugs, which are the most widely prescribed drugs for the treatment of acute and chronic pain, which account for about $6 to $7 billion in the sale worldwide. These are diverse group of chemically unrelated compounds. Unrelated, but all of them share the same mechanism of action that are classified together based on their therapeutic property of possessing an anti-inflammatory action. First published report on use of salicylic acid was by Edward Stone in 1763. He treated 50 rheumatic patients with bark and leaves of willow, myrtle, and other plants. At 1971, John Vane elucidated the mechanism of non-steroidal anti-inflammatory drugs and shared the Nobel Prize with two others in physiology and medicine in 1982. The mechanism of action, central action, appeared to be more involved than previously thought, peripheral action only. Actually, the main mechanism by peripheral sites, but nowadays there is increasing the role of central action in addition to the peripheral one. There are multiple isoforms of COX with different activity. Effect of COX inhibition by most non-steroidal anti-inflammatory drugs. Here, COX-1, the inhibition of COX-1 result in gastric ulcer leading acute renal failure, while the inhibition of COX-2 lead to reduced inflammation, reduce pain, reduce fever. So this is harmful inhibition, and this is beneficial inhibition. Means this is beneficial enzyme, and this is the harmful enzyme. An enzyme involved in prostaglandin synthesis, cyclooxygenase 1 and 2. Cyclooxygenase 1 beneficial prostaglandin, and it is inhibition by non-steroidal anti-inflammatory drugs result in gastric ulcer, bleeding, and acute renal failure. So this is beneficial prostaglandin and harmful effect of non-steroidal by inhibition of the beneficial prostaglandin. And regarding the COX-2, harmful prostaglandin and its inhibition by NSAIDs result in a reduction of pain, fever, and inflammation. So this is beneficial inhibition, while the prostaglandin themselves are harmful. Classification into selective COX inhibitor and non-selective COX inhibitor. Selective, non-selective. This is the mechanism of action. Arachidonic acid, COX-2, COX-1. COX-2 lead to prostaglandins, and here COX-1 lead to prostaglandins and glucotrienes. Non-steroidal anti-inflammatory drugs inhibit this enzyme, lead to no more prostaglandin here and no more prostaglandin and glucotrienes here. These prostaglandins, primary mediator for inflammation and fever and pain. So this inhibition is beneficial because these are harm prostaglandin. While this prostaglandin primarily protects GIT tract mucosa, primary support platelet function. So these are beneficial prostaglandin and its inhibition lead to harmful effects. Mechanism of action in general inhibits cyclooxygenase, prevents sensitization of peripheral nociceptor by diminishing the prostaglandin formation. Most commonly stated mechanism. This is the most commonly stated mechanism. Other mechanisms, cellular effect, unrelated to prostaglandin, inhibits the release of inflammatory mediators from neutrophils and macrophages. Also produces analgesia through central nervous system mechanism by reversing inhibition by prostaglandins of opioids-mediated pain modulation. This is the differences between COX-1 and COX-2. Peripheral injury site, here inflammation in the brain, modulate pain perception, promote fever, hypothalamus, vasodilatation. On the stomach, COX-1, which is beneficial, protecting mucosa. On the platelets, we have two opposed effects by different prostaglandins. Two opposed effects. One of them, aggregation, and this is through thromboxane. Thromboxane stimulates the aggregation of platelets after, for example, injury. So this thromboxane associated with thrombosis. But we have another type of prostaglandin, which is called the prostacyclin, actually, that reduce the aggregation of platelets. Reduce the aggregation. So I put it and highlighted in the red color because this is very important. And maybe this is the only important side effect of using of COX-2 inhibitors. Using of COX-2 inhibitors lead to a reduction in this function, which is reduce the aggregation, and by indirect way increase the aggregation of the platelets, which in turn causes more CVA attack or ischemic heart diseases like angina or myocardial infarction, associated mainly when using COX-2 inhibitors in patients at risk. And we will talk about in the next slides, but you have to bear in your mind the mechanism through which the CVA or ischemic heart disease can be triggered by using of COX-2 inhibitors. On kidney, there is vasodilatation by COX-1 and maintained renal function by COX-2. COX selectivity for classes: aspirin, irreversible inhibition of both COX-1 and COX-2; ibuprofen, reversible competitive inhibition of both isoform; and we have chlorbioprophen, slower time-dependent inhibition of both isomers; and we have Celecox, largely affect the COX-2 selective. So there was one of the questions in the start of this presentation regarding the effect of aspirin on COX-1 or COX-2, which is actually affect both. So better to say it is non-selective inhibitor rather than the COX-1 or COX-2, because the term of COX-2 selective may give wrong idea that other drugs are with COX-1 inhibition, while actually other drugs, not COX-1, but both COX-1 and 2 inhibitors. So better to say this is selective inhibitor, that is to say COX-2, and this is non-selective inhibitor, means both COX-1 and 2. Indication of non-steroidal anti-inflammatory drugs: acute pain syndrome, perioperative pain control, chronic inflammatory pain, chronic non-inflammatory osteoarthritis pain, cancer pain, neuropathic pain. The side effect: allergy and hypersensitivity, gastrointestinal effect, hematologic effect, cardiovascular effect, renal toxicity, hepatic toxicity, central nervous system toxicity. So here there's long list of important side effects of the non-steroidal anti-inflammatory drugs, but fortunately most of these side effects does not appear when used in the short-term course, but can be precipitated with the use in a chronic way. There are several controversies about the non-steroidal anti-inflammatory drugs. First, increased risk of bleeding, impaired bone tendon healing, cardiovascular effect. هالة تحسين.
نعم أستاذ.
هالة تسمعيني؟
نعم أستاذ أسمعك.
اوكي هالة شنو هذا الكلام regarding the increased risk of bleeding controversies؟
يعني قصد أستاذ إنه risk over benefit؟
لا هو يعني يقول لك اكو يعني فالجدل على موضوع انه non-steroidal increase the bleeding, use of non-steroidal.
ما أعرف أستاذ. I don't know.
زين جيد. رند محمد. رند محمد. هدى فاضل عوفة. هدى ضيف علينا. عمر قاسم.
نعم استاذ.
عمر, what about cardiovascular effect controversy?
Really, I don't know specifically.
You don't know. I have just talked about cardiovascular effect of a patient with COX-2 inhibitor.
اي استاذ, هو قلنا يزيد الهايبر كوجيوبل ستيت يسوي بالكوكس 2 انهبيتر, لان هي الكوكس 2 بالاصل انهبت بلاتلت اجريجيشن, فمن ننطي كوكس 2 انهبيتر وينديوس هايبر كوجيوبل ستيت في ذا بيشنت, بالتالي يسوي لنا ثرومبوسيس وامبوليزم.
Okay, thank you. And now I will talk about the side effect, and starting with GIT side effect. At 1938, earliest GI side effect evidence with aspirin. At 1970s, increased use of gastroscopy and introduction of several new non-steroidal anti-inflammatory drugs revealed more evidence about the side effect of NSAID in the GIT system. This risk increase when the patient more than 60 years old, in patient with past history of peptic ulcer, in patient on steroid use, in patient on alcohol, patient using multiple NSAID first 3 months of use. These are the risk factor or the factors that increase the risk for GIT bleeding. So we have what is called Aramis scale, and according to this scale, we can decide to use or not to use of NSAID and which type of NSAID to be used according to the score of Aramis. The Aramis model for estimating the risk of gastric ulceration while taking non-selective NSAID. A score more than 1.5 is considered high risk and a contraindication for the use of non-selective NSAIDs. The scale is for chronic use over 12 months period. So this is scale not for the using of short-term non-steroidal anti-inflammatory drugs. The scale starts at a score of 0, add 0.3 for every 5 years of patient's age over 50. So if the patient 60 years old, we will add 0.6. 55 years old, we will add 0.3. Add 1.2 if the patient is receiving a corticosteroids, for example, asthmatic patient or other autoimmune patients. Add 1.4 if the patient has reported a previous NSAID-related GIT side effect. Add 0.5 if the patient has sustained disability. After summation of these points and account the precise scale, we can decide whether to use or not to use non-steroidal and which type of non-steroidal to be used. Also, we can prevent the side effect by using of antacids, intercoating of non-steroidal anti-inflammatory drugs, H2 inhibitor with limited success. Also, we have saccharate, misoprostol, but this associated with diarrhea in 50% of users. Proton pump inhibitors, omeprazole, more effective than H2 blockers, and also one of the prevention, the use of highly selective COX-2 inhibitors. These measures can decrease the side effect, GIT side effect of NSAID. And regarding the renal side effects, renal impairment in 18% of patients using NSAID for long period, and acute renal failure in about 6% of those using NSAID for long period. And these two side effects clinically significant in patients with heart failure, renal insufficiency, and liver disease. أحمد عباس.
نعم أستاذ.
أحمد عباس شنو كنت؟
نعم أستاذ.
قبل شوية لو وين كنت؟
وياك أستاذ واضح.
مو هسه قبل نص ساعة 3/4 ساعة من صحتك ما كنت موجود.
لا أستاذ جاوبتك. سألتني بالبداية أول شيء سألتني أول سؤال أنا اللي سألتني على بالبداية المقطع مال كلورافاي himself و
أوكي.
هذه أي أستاذ بلي.
أحمد.
بلي أستاذ.
What do you think regarding the patient using NSAID for long period? Do you think their number in our community is wide number or low number?
أستاذ بالنسبة للنسايد يعني إنه
نعم
غير إنه long time very wide يعني حسب اللي جاي نشوفه إنه كله chronic و by hand use.
Why? This is due to the fault from the doctors or from the patient?
أستاذ أعتقد يعني from the patient ويعني by hand دين بقى إنه بالصيدليات يعني الفارمس كله by hand.
agree with you totally. أنا قبل ما أشتغل بالpain management كنت بعيد عن using of non-SED I mean orally نستخدمها كنا بالعمليات نستخدم الفولترين نستخدم الكيتورولات بس ما نعرف يعني the wide range of using outside for outpatient. لكن من اشتغلت بالبين مانجمنت اكتشفت انه الناس معظمها تستخدم الانسيد just like paracetamol يسموه over counter use. فيجوني ناس صار لهم سنين يعانون مثلا من ظهرهم او من الركبه مالتهم او السيرفايكال مثلا vertebrae فتقول له على شنو مثلا انت تستفيد؟ يقول لك والله دكتور مثلا لو اخذ الفولتا يعني يقول لك فولتارين بس يقول لك هو يعني هاي كلماتهم دا نقولها انا الفولتارين ما يشتغل علي مثلا الموبيك وش قد صار لك على الموبيك؟ هاي صار لي سنين دكتور على الموبيك. ف unfortunately we can't according to these saying know the wide range of this problem because most of those patients already we can categorize them as elderly age group and using of such drugs for long term lead to one of the side effects, renal side effect, and most of them already with chronic systemic diseases, hypertension, heart failure, renal insufficiency, can be aggravated by the use of NSAID. So my advice to use NSAID on need for short course only and after that to stop it and replaced by other long list of medication. Thank you, Ahmed.
شكرا استاذ العفو الله يحفظك.
Hematological side effect. Aspirin inhibits platelet activation irreversibly, and you know that. This takes 7 to 10 days to recover. Non-steroidal, other non-steroidal other than aspirin include reversible platelet inhibition that resolves when a drug is eliminated. Most NSAIDs potentiate anticoagulant activity of warfarin. حكينا عنها بالمحاضرة السابقة. علي ناظم.
نعم أستاذ.
حكينا مو عنها بالمحاضرة السابقة هاي.
اي نعم أستاذ.
Potentiate anticoagulant activity of warfarin. How? Zina.
نعم أستاذ.
How? By which mechanism, Zina?
أستاذ, both of them protein binding.
Very good. And this place this decreased the protein binding of warfarin by 50%. So
doubling the effect. Yeah.
So we'll double the effect of warfarin by using aspirin. Cardiovascular system safety controversy I already talked about, but here in details, Vioxx gastrointestinal outcome research study followed by some other studies have raised questions about cardiovascular safety of COX-2 inhibitor and NSAIDs, suggested a higher incidence of cardiovascular thrombotic events by rofecoxib and varicoxib. Recently, the use of rofecoxib and varicoxib has been reported to be associated with increased incidence of MI and stroke. Hence, they have been withdrawn by the original manufacturer. Currently, all the selective COX-2 inhibitors are under suspicion regarding their long-term toxicity. They have been described as drugs with marginal efficacy, heightened risk and excessive cost compared with traditional NSAID. COX inhibitor is constituted in kidney, brain, and inflamed area. Long half-life, about that 11 hours. GIT side effect reduced to 50%, so less bleeding and ulcer. Minimal renal effect. No effect on bleeding time. Not inhibited platelet. Contraindication in patient with chronic renal insufficiency, patient with heart disease, patient allergy to aspirin. Before talking about hepatic toxicity, I want to say my experience with the use of COX-2 inhibitors in my daily work with pain management. I used to use recent type arcoxia of COX-2 inhibitor, means selective inhibitor, in any patient below 45 years old and has no past medical history of cardiovascular system. In cases of patient older age or patient with history of hypertension or other cardiovascular disease, I prescribe non-selective NSAID if there is no contraindication for the use of them. So it is used, COX, and beneficial, I mean the selective, beneficial, if used in good rationale, and if not used with the patient with high risk of developing cardiovascular complication. Regarding the hepatic toxicity, liver-related side effect reported in 3% of users. أكو دواء اسمه سولنيداك create higher risk of hepatic damage, although mild and reversible. Diclofenac with fulminant hepatitis reported. When I'm saying reported, means very rare that reported in certain case, in certain place. So just to put in mind, but it is not common and not repeated frequently. Recently, bromafenac was removed from US market due to lethal liver damage. Guidelines for use: patient with no cardiovascular system and low or no GIT risk, monotherapy with non-selective NSAID. Patients who do not require aspirin and have GIT risk, COX-2 inhibitors, or non-selective NSAID with proton pump inhibitors. Patients with cardiovascular risk avoid COX-2 inhibitors. So if there is no GIT risk, you can use only non-selective NSAID. With GIT risk, you can use non-selective NSAID with proton pump inhibitor. To conclude, risk must be weighed against the benefit, particularly when long-term use is anticipated. We talked about non-steroidal anti-inflammatory drugs in general, and now we'll focus on aspirin as example, important example actually, of non-steroidal anti-inflammatory drugs. Pharmacological effect of aspirin: first, analgesic effect. Prostaglandin E2 is thought to sensitize nerve ending to the action of bradykinin, histamine, and other chemical mediators released locally by the inflammatory process. Thus, by decreasing the prostaglandin E2 synthesis, aspirin and other NSAID repress the sensation of pain. Antipyretic effect. The salicylates lower body temperature in patients with fever by impeding prostaglandin E2 synthesis and release. Aspirin resets the thermostat towards normal, and it rapidly lowers the body temperature of febrile patient. Fever is caused by prostaglandin 2. This is mechanism of developing fever by prostaglandin E2 synthesis, which is stimulated when endogenous fever-producing agent, which called pyrogen, such as are released from white blood cells that are activated by infection, hypersensitivity, malignancy, or inflammation. And to summarize that here, infection, hypersensitivity, malignancy, or inflammation, any one of these can lead to release of white PCs, and this white PCs liberates cytokines which stimulate and trigger the synthesis of prostaglandin E1, which lead to fever. So inhibition of prostaglandin by aspirin lead to decrease the fever. Now, regarding the anti-inflammatory effect, prostaglandin in inflammation lead to vasodilatation and increased vascular permeability. Inhibition of prostaglandin by NSAID attenuate, not abolish the inflammation. Anti-platelet effects, low doses, 60 to 81 milligram per day of aspirin can irreversibly inhibit thromboxane production in platelets via acetylation of cyclooxygenase. Because the platelets lack nuclei, they cannot synthesize a new enzyme, and the lack of thromboxane persists for the lifetime of platelets, about 9 days. So it is actually irreversible. Action on the kidney, cyclooxygenase inhibitors prevents the synthesis of prostaglandin E2 and the prostaglandin I2, prostaglandins that are responsible for maintenance of renal blood flow, particularly in the presence of circulating vasoconstriction. Decreased synthesis of prostaglandins can result in retention of sodium and water and may cause edema and hyperkalemia in some patients. And also, if we talk about uric acid, uric effect, aspirin is known to have a biomodal effect on the renal handling of uric acid. High dosage, more than 3 grams per day, are uricosuric, while low dosage, 1 to 2 grams per day, causes uric acid retention, hyperuricemia. Gastrointestinal effect, we talk about that. Respiratory effect, and this was one of the questions in the introduction at the start of this presentation, why the non-steroidal contraindicated in patients with asthma. Inhibition of COX lead to formation of more leukotrienes via lipooxygenase pathway that result in bronchospasm. We have cyclooxygenase enzyme and lipooxygenase enzyme. Inhibition of cyclooxygenase enzyme by non-steroidal anti-inflammatory drugs lead to indirect increase in the production of leukotrienes via lipooxygenase pathway that result in bronchospasm. Higher doses work directly on respiratory center. This is another effect in the medulla, resulting in hyperventilation and respiratory alkalosis that usually is adequately compensated for by the kidney. But at toxic level, central respiratory paralysis occurs and respiratory acidosis ensues due to continued production of carbon dioxide. Clinical uses, we talked about that. Pharmacokinetic, weak organic acid completely absorbed from GIT, peak blood level after 1 hour, orally, rectally for children can be used, metabolized in the liver and excreted in the kidney with the urine. adverse effect we talked about. But here, there is a syndrome, which is Reye's syndrome, in which salicylates must be avoided in children and teenagers less than 15 years old with varicella, chickenpox, or influenza to prevent Reye's syndrome. Although it occurs rarely, there is a 20 to 30% mortality. الحقيقة احنا من كنا أطفال الأسبرين لونه وردي والطعم مالته يعني شوجر وشوجر يعني شوجر تيست، فكل الأطفال كانوا يكرزون بالأسبرين يعني أشبه بالحامض حلو، فأي واحد يصير عنده فيبر يكيف الطفل يروح يقولها الأم، هو يقولها الأم اعطينا أسبرين. ما كان هذا السندروم well known. Maybe I'm talking about maybe 35 to 40 years ago. Nowadays, it is well-known disease, Reye's syndrome, and as this disease is associated with sophisticated percent of mortality, 20 to 30% high mortality, although it is a rare syndrome, but this mortality obligates us to avoid use of salicylate in the children less than 15 years old. It is a life-threatening metabolic disorder in young children of uncertain cause, but sometimes precipitated by aspirin and involving encephalitis and liver failure. Blood sugar level typically drops while the level of ammonia and acidity in his or her blood rise. At the same time, the liver may well swell and develop fatty deposits. Swelling may also occur in the brain, which can cause seizure, convulsions, or loss of consciousness. The signs and symptoms of Reye's syndrome typically appear about 3 to 5 days after the onset of viral infection. Drug interaction with heparin or oral anticoagulant lead to hemorrhage, anti-acid, reduce aspirin absorption. Some drugs increase plasma concentration of aspirin. Overdose toxicity of salicylate called salicylism. The symptom nausea, vomiting, headache, dizziness, tinnitus, and mental confusion. The signs, which is important, electrolyte imbalance, hyperthermia, hyperventilation, convulsion, respiratory and metabolic acidosis, and may lead to mortality and death. The treatment of salicylic acid toxicity by gastric lavage, O2 supply, activated charcoal as chelating agent, sodium bicarb to antagonize the acidity, IV fluid, and in severe cases, hemodialysis may be required. Now, the ketorolac, very inherent to our daily work because it was the only intravenous non-steroidal anti-inflammatory drugs for long years. And in the recent years, the diclofenac added in certain type to be used as intravenous. This has less anti-inflammatory activity. Intramuscular can be used 20 to 30 milligrams single dose. Is a moderately effective analgesic in patients with moderate to severe post-operative pain. Intravenous ketorolac has been as effective as and have fewer side effects than morphine in surgical and chronic cancer pain. Has longer duration of action, half-life about 5 hours, metabolized in the liver and excreted by the kidney. Last topic about tramadol. Tramadol, it is a codeine analog used as an alternative to NSAID and opioids, more potent analgesics than NSAIDs with fewer side effects. Oral formulation can be used by immediate release 50 milligram or combination with paracetamol in a doses of 325 of paracetamol to 37.5 milligram of tramadol, or as a sustained release 100 to 400 milligram. It is weak opioids because has a weak effect on some opioid receptor, which are mu and delta, and also has other mechanism of effect or other sites of action. For example, here norepinephrine and serotonin reuptake blocker and also enhance its release. And this is just like the effect of antidepressant drugs. So this drug may has antidepressant effect and also has alpha-2 receptor agonism. These actions are synergistic for analgesia. So here we have 3 mechanisms of effect of tramadol, and analgesia partially blocked by naloxone. So this tramadol regarded as weak opioid because has weak effect on opioid receptor and also partially reversed by naloxone. We have rhythmic drug, positive and negative. Positive one more affinity, has more affinity for mu receptor. Negative stimulate alpha-2 receptor, lead to increase of norepinephrine. Metabolized in the liver, 30% excreted unchanged in the urine. M1 metabolite active 6 times potent than the parent drug. The bioavailability of tramadol about 75% and the protein binding about 30%. Amir Hamid Al-Hakim.
Very start, Osman.
What is the bioavailability, Amir? What does it mean? Bioavailability?
Amount of drug reached bloodstream.
Very good. So here there is a bioavailability of 75. That is to say 75% of the original dose reach the vascular system. Good, Amir. The analgesia peak effect after 2 hours, lasts for 6 hours, steady state for 48 hours, absorption unaffected when taken with food, but time to peak plasma concentration increases. Dose adjustment should be in the elderly, renal, and patient with renal or liver diseases. The dosage 50 to 100 milligram every 6 hours. Maximum dose 400 milligram per day. And we can titrate the dose for those who are elderly age group or has risk or sensitive to the tramadol. We can start by 50 milligram per day for 3 days and increase by 50 milligram every 3 days until reaching the 200 milligram per day. Or we can start by 25 milligram per day for 3 days, increase by 25 milligram every 3 days to 25 milligram سموها KID. And here I have written the difference between QD or QID. QD means 1 per day, like here, and this KID means 4 times per day. This from quaternary per day. Quaternary per day. Indication, you know the indication of tramadol and the side effect: dizziness, lethargy, nausea, vomiting, constipation. Nausea, vomiting may improve after 1 week, but lethargy and constipation may fail to do so. Also, we have the serotonin syndrome, abrupt change of mental state, fever, shivering, diaphoresis, nausea, vomiting, tremor, myoclonus, and the treatment by systematic management and cyproheptadine. Thank you very much. If you have any question, I'm ready to hear and answer.
شكرا جزيلا استاذ زحمناك.
شكرا جزيلا استاذ. بس بدون زحمه السؤال استاذ. الو
تفضلي. اسمع
استاذ. بس بالنسبه للاسبرين يعني ورا ال 9 داي ترجع بليتلت نورمال اكشن؟
يس.
اوكي دكتور زين. يعني اذا نسوي توب امرجنسي اوبريشن لازم ايش قد يعني كم ساعه يلا نقدر نسوي الاوبريشن؟ يعني الى وقت محدد اذا كان البيشنت ماخذ اسبرين؟
عندك emergency surgery؟
اي اوكي. اي استاذ.
فهنا انت بعد ما تقدرين يعني توقفين الاسبرين لان هي emergency surgery انت تحكي معناته
بس صدق يقطع.
تقدرين تنطين transfusion of platelet.
transfusion. اوكي دكتور شكرا جزيلا.
Other questions or comments? Okay, thank you very much and goodbye.
Goodbye استاذ. شكرا جزيلا.
الله يعافيك استاذ. مشكورين. الله يعافيك.
شكرا جزيلا استاذ.
شكرا جزيلا استاذ.
شكرا جزيلا استاذ.